Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here at the AusACPDM conference in Cairns, Australia, to interview world-leading researchers, clinicians, and people with lived experience
to support your practice in being more evidence-based.
Welcome back to AusACPDM. We are joined now by the wonderful Marissa Smith, who is a physiotherapist and clinical coordinator at the Healthy Strides Foundation. Hi, Marissa.
Hi, Ash and Dana.
Hello.
Thanks for having me.
Oh, it's nice to have you on the other side of this.
I know, yes. Some people may recognise Marissa's voice as co-host of the podcast.
Yeah, and so this is a different side today, being the person who's getting asked the questions.
On the other side.
Yeah. Are there any impersonations coming up this time round?
Not today, no.
That's a shame.
They've gone.
I am disappointed to hear that. I've never been in the room when
they're not occurring on air again.
We'll see about that.
I think we can try. Yeah, it brightens
challenge accepted. Yeah. But we're not here to talk about impersonations.
No, that's right.
They might come out later, but we are here to talk about your paper, Marissa, Functional Mobility Matters, Embedding Motor Learning Interventions Using Dynamic Robotic Technology. And I've had a look at the abstract and I'm pretty excited about this one.
I love this. The more times I read through it and in preparing the presentation, it makes me excited.
Yeah.
That's cool. I love that. Well, talk us through a bit about why you did this work. Like why is this work important? What gap were you trying to fill here?
The gap was, as clinicians, our common goal is around functional mobility, around improving independence across different contexts for children. And particularly for children around that GMFCS 2 to 3 level where they would have independence maybe with a walker or in their wheelchair. But there's some environments that are quite complex, like busy classrooms or bathrooms. And if we think they have the potential, if we could get them to mobilise, for example, with crutches or with a bit less support, it would greatly increase their freedom and independence.
Yeah.
And so the reason behind all of this is we're fortunate to have the piece of equipment, the Zero G, which I can go into more if you like at some point, but is how we can challenge children. We can challenge them safely, aligning with all the things we know work best for therapy, all those green light interventions. Challenge them safely to be able to develop their functional mobility skills to, do you know what, just push that bar, their potential, and so maybe go from using a walker to crutches and the freedom that allows. So really as therapists, put in the forefront of our mind what children have to do on a day-to-day basis. How can we push them to really maximise that potential? And how do we as therapists train that safely?
I think you've summarised that beautifully.
That was really nice. And I would have to say what came to mind, like I can literally see it in my head, is the ICF right now. And you're talking about how we can maximise their activity and participation so they can be as independent as possible. But the part that you're really tapping into here is those little bubbles at the bottom that we often have there, but what do we do about it? Is the environmental factors and the personal factors. So you're talking about a group of kids here who have that mobility, but they need that little bit more because they want to be a bit more independent. And you're thinking about the environmental aspects here, aren't you?
Absolutely. It's things like, we obviously in clinical spaces have space and, there's not clutter, but, stand at home, toys everywhere or really
Lego
narrow.
pieces.
Exactly. Bits everywhere. Really narrow hallways, small bathrooms, they've got to negotiate around and it's particularly just being able to challenge children. And often as therapists, sometimes because of safety, we can't and we don't want to, but that's something that the Zero G really allows us to safely challenge children and to be able to make those improvements.
And we'll touch on the Zero G and what an amazing piece of equipment that is in a second. But before we do, can you just summarise really quickly for the listeners what your research question was, given all that beautiful context you've just provided?
It was, could using robotic technology improve functional mobility? And using a single case design.
Okay.
Lovely.
We love a single case design.
I've learned a lot as well about single case designs.
Okay, so tell us about your single case design. Who was involved? How long did it go for?
So our single case design is based on a 7-year-old boy with cerebral palsy. He's classified within GMFCS level 3 and his FMS pre was 221. So this child, for who we did the single case design on, attended 2 programs over a 9-month period. The first program at the very start was 6 weeks long, was made up of 3 2-hour sessions a week. Then there was a break of around 7 months.
Yep.
And then at the end of the 9-month period, he attended another 4-week program.
Yep.
Again, 3 sessions a week for 2 weeks.
Okay.
It's important to note that he had no other intervention during that time.
Okay.
And in the 2-hour sessions, the majority of the first hour was spent in the 0G, with the second part being out of the 0G.
Okay. Now, talk to us about the 0G.
Yes.
Oh, look, love this piece of equipment. Absolutely amazing. So 0G we describe as kind of like the missing link. It's a dynamic body weight support system where the child wears a harness and then they're tracked up to the 0G, which is an overhead tracking system as well. But what's so amazing about the 0G is it provides dynamic body weight support. And being dynamic means it can be incremented, it can change. As the child develops, you can reduce that body weight support.
Right.
So it allows for those incremental challenges. But also you can set a falls control to catch the child and mean that you can be hands-off as a therapist. You can teach the child the mechanics of how to move, whether it's with elbow crutches or to transfer on and off the floor or, a variety of gross motor skills with your hands off. And you know that if they lose their balance, they're going to be safe. So it's otherwise, without the 0G, your hands are either on or they're off. And it's kind of what makes us nervous as times as therapists to challenge children is that they're not safe. 0G allows you to do that. And you can get a lot of repetition because they are safe.
Such a game changer, isn't it?
It is, We've seen it in action and understanding, I suppose, what it's going to do from those active ingredients, those green light interventions. Because it's the hands-off part that is the key. Like, there's no sports coach. We've spoken about this before. There's no sports coach that's going to, you play tennis. Did someone hold your hand for the
No, you can't.
You can't, right?
It's all hands-off. And
So I think it's seeing yourself more as a coach. As a therapist, you're a coach because you want that person to learn the motor skills, have their own pathways, and problem solve. I think that's the part that it's hard to do in therapy sometimes because you want to see them succeed, but error is equally as important.
Right. And what that reminds me of is the co-op approach that we talk about sometimes, cognitive orientation and getting kids to develop strategies themselves to overcome problems or achieve goals that they might have is very powerful. And the carryover effect they see goes much long term. So you're not constantly relying on therapy to do your tune-ups. You're empowering the person to be in control of their body and to understand how it reacts. And I think of that research that was put out when we talked to Andrina Sabe and Heather Feldner. And they were talking about toddlers and how they fall like over 100 times in a very short period of time. And it's acceptable. We know it needs to happen. But if our children don't learn how to fall safely once they're a little bit bigger as well, they're going to become fearful and not have those strategies.
And that's the good thing about the 0G is they can fail or fall as such and they're safe. They're not going to get an injury that then makes them stop. They get up, they keep going. And it's that you get so much repetition and practice because they are safe. And then as they improve on a skill, you can reduce that dynamic body weight support as well.
And from a safety perspective, from a therapist, if you see a child falling, you're not really meant to catch them if you're going to hurt yourself because that's a big health, safety risk. But you don't have to worry about that.
And I think about the confidence that must give the child as well to be able to give things a go in a really safe environment and not be anxious about falling or hurting themselves. It must just be really freeing.
And it shows them what they're capable of. So for the child in the single case design, using crutches at the start was something obviously not familiar. And so it's building up knowing, okay, I'm safe, I can give this a go. And then that fear element leaves and they can really focus on learning the movement and the skill rather than being so nervous about it and nervous about falling.
That's right.
So many good things about it.
Can I quickly touch on, I know we've spoken about single case experimental design, SCEDs, and this was done on one child, which is still really robust. But why is a single case design more robust than what people often would think is a case study? I think that's worth touching on.
So the single case design, it involves intensive data collection for that child over the intervention period. And it's made up of 2 distinct phases. So we've got the baseline phase and once a stable baseline is achieved, we can move into the intervention phase. And the reason it is so robust is that the effect of the intervention is measured after every session and we use that 10-point scale based on the target behaviour. And so at the end of every session, we're able to quantify where the child is progressing towards their goal. This is all assessed by visual analysis. And then there's other statistical measures like the tau-u and the percentage of non-overlapping data that also adds I guess, extra rigor to what's behind the SCED.
Yeah.
Cool.
Yeah.
Yeah, it's good. I love it.
I'm itching to know.
Oh, yes, I love this. I get excited.
Yeah. What did you find?
Oh, so many exciting things. I'll bet. So clinical measures. So the child's GMFCS percentile for his age and GMFCS level went from the 40th to 60th percentile.
Wow.
From the first program to the second
program, yeah. So when I'm talking now in pre and post, pre is before both programs.
Yes.
And post is post the second program. So there's a 9-month period.
So at the end of that 9-month period.
So when I should clarify that. In terms of 10-metre walk test, there was clinical significant improvement in his walking speed. 6-minute walk test distance more than doubled.
Wow.
But what was most significant is that he went from needing 22 catches or losses of balance in his first baseline 6-minute walk test to no losses of balance at post, which then translates to his FMS improving from a 2-2-1 to a 3-3-1.
2-3-2.
Oh, well, yes, he does use it. Yeah,
Yes.
It kind of goes between one and
his choice,
longer
isn't it?
distances.
Yeah.
So the big thing is that he was able to use elbow crutches indoors and short distances outdoors where he was normally using a walker.
Yeah.
So for this child, I love this video we have of him at home and using his elbow crutches in his living room to get down his narrow hallway that he otherwise couldn't access into the bathroom.
Yeah.
Wow.
And so that's a huge game changer.
Yeah.
So if his functional mobility improved and he was able to do that safely, and his parents felt safe with him doing that, his parent, which is amazing. So
good.
yeah, that was a huge thing.
Yeah.
That's a thing.
And really highlights what you were saying before about the environment and, coming back to the ICF, how what that really looks like in real life. It's, seems quite innocuous to some people, but actually to that family it's
huge.
A huge change and very liberating for that child.
Yeah. It gave him that freedom and confidence to do that. And I think it translated to other situations as well, whether it was in the playground and in the classroom. And even where he's at with his age being 7, he's able to the fact that he can balance and have those those reactions. And, there's a lot more body weight going through your legs when you're using crutches than the walker in terms of less fixing through his upper limbs. Just puts him in a really good position in terms of where he's at with his age and what he is capable of and also as he gets older.
Yeah. This is maybe a tricky question because I want to touch on, I suppose, what clinicians can take away from this work because I think, there's lots of really important takeaways. Yeah. But I also want to know kind of within that what they can take away if perhaps they don't have access to a 0G. What are the things that you've learned in doing this study that you think are applicable to all clinicians, whether they have access to a 0G or not?
I think it's looking at, we always look at the child and thinking about what environments they access on a day-to-day basis and what equipment may help them access those environments with more freedom, and particularly those that are GMFCS3 that at times we're like, can we, reduce their supports on their walker? Could we progress them to elbow crutches? And if you think they can safely, then it's working a way of being able to train for that. That's what we are as physiotherapists. We're there to train to obviously have those improvements. And then looking at our dosage around therapy and looking at all those green light interventions, those active ingredients in terms of how we're then dosing our therapy and what we're doing, the hands-off approach. Yeah. How do we do it safely?
I think it reinforces the hands-off approach. Well, it reinforces the active ingredients. So, yes, you might not have a 0G, but it almost reinforces beautifully by saying, actually, if you are hands-off, you can allow them to practice as much as you can and you can make it as safe as you possibly can. But I don't know about you. I go to lots of health conventions or conferences and people have got so much robotic equipment around. It's the new thing, right? Finding the right technology. And I think I don't know, from my perspective, I would try to find the right kind of equipment that actually matches the active ingredients.
Yes. Absolutely, because you don't want something where the child is being passive. Yes. If their goal is to learn that skill. Yes. If it's for some other reason, then that's, but at the end of the day, we know to improve a gross motor skill, you need that active.
You need to do it.
Ingredients and the child being active. So the 0G is that kind of perfect technology to fit with all those green light interventions.
How exciting.
Yeah.
Yeah, it's really cool. And I think one thing, just to quickly wrap up on that point that you made was There was a phase where a lot of people were looking into the Locomat, for example, for kids with cerebral palsy. They've done a lot of studies in it, and what they really came out to say, and Diane Damiano said it just did too much for them. And so it looked really great from a piece of technology, because these are all expensive pieces of equipment, but it did too much and they didn't get the right outcome. So it's finding, when you're looking for a piece of equipment, it's aligning it with those active ingredients.
Yeah, absolutely.
Yeah. Whose brain's doing the work?
Whose brain's doing the work?
Because at the end of the day, obviously, it translates to when they're out of the equipment. That's when it really matters.
Yeah.
It doesn't matter how they look necessarily. Well, obviously, you want them to be comfortable in the
of
equipment,
course,
but it's not about their alignment in equipment. It's about them, what happens when they're out of it.
That's so cool.
Yeah.
Nice. Thank you.
Thank you for coming on, Marissa.
Thanks for having me.
Enjoy the rest of the conference.
Will do.
And everyone else, stay tuned for more research works at AusACPDM.
Talk to you again soon.
Bye.
Bye.